This presentation is recorded for HIM 2214 Health Statistics from the textbook Basic Allied Health Statistics and Analysis, 3rd edition. Chapter 2, Healthcare Overview and Patient Data Collection. The objectives for this presentation are as follows. Define ancillary service care, primary care center, incident reports, respite care. Identify the following abbreviations: SNF, ICF, PPO, HMO, MCO. Distinguish between inpatient care and outpatient care, acute care and long-term care, bed statistics and bassinet statistics, intra-hospital transfer and discharge transfer, child and adolescent for hospital statistical purposes, retrospective and concurrent methods of data collection, emergency room, department and trauma center, assigned basic service classifications. When we look at health statistics, and we look at, because most of our statistics that we're discussing are coming from, we're looking at hospital healthcare statistics, but there's really been an evolution in healthcare in reference to how much utilization is attributed to hospitals. One thing is that hospital care is more expensive than your ambulatory care or your care that's done on an outpatient basis. So there has been an evolution. The hospitals is no longer responsible for the majority of care in our continuum of care. Outpatient care has actually become more significant. And many of the statistical measures that we are going to discuss during this class, which I mentioned earlier, are going to be applicable to outpatient care. We also want to remember, and I'm going to say it over and over again, that statistics are only as accurate as the original data from which we obtain it. Okay? We also need to be concerned about what type of data and how much data we are capturing. And that, the kind of data and the extent of the data that we collect is going to vary by the institution. Institutions service different types of patients, they provide different types of services, and so they're going to have different needs. And because of those different needs, they're going to need different kinds of data and to different extents. Now, we talked about the needs of the institutions will vary based on the different types of institutions, and so therefore our focus needs to move to those types of institutions. Now, we've had this conversation before in terms of those types of facilities or types of care that we find on that healthcare continuum. And so in most of our classes, there is an overlapping discussion about this, but we go off into different pathways in terms of discussion. So hospitals is one of the mainstays of healthcare, and we know another word for hospital is acute care. You may hear it called short-term care, and this is care that happens on an inpatient basis, and it's around the clock. Now, hospitals, due to that evolution that we have been talking about, you can now find some hospitals that also provide outpatient services as well. Your emergency department would be considered outpatient services. We also have different types of hospitals that provide different types of services. Now, long-term care You may see this written as LTC, that stands for long-term care, but you also have extended care facilities and nursing homes. ECF is for extended care, NH for nursing homes. And basically your LTCs, your long-term care, they are not as expensive in terms of the care that they provide as an acute care hospital. They're actually a level lower in terms of care than a hospital. They do have inpatient care that's provided. They can get a long-term care bed and get round-the-clock care, but the level of care is not going to be to the extent of a hospital. Now, when we're looking at long-term care facilities, there are different types. You got your SNFs. That's your SNF. We call it SNFs. That stands for skilled nursing facilities. This is your highest level long-term care that you can get. So they can have, and the SNFs, they serve dual populations. You have some patients that will stay more of a long-term, like years, and then you got others who only stay for a couple of days or a couple of weeks. For maybe they were transferred from a acute care type facility, and so they are dealing with some type of acute episode, and so they don't have to stay as long. So they can have patients who stay a long time versus those who stay a little shorter time. So that's a dual population. For example, they may come over from acute care dealing with some type of stroke or hip replacement or something of that nature. Now, the level right below your SNF would be your intermediate care facility, your ICF. They have long-term care services on a more limited basis than what you would find in a SNF. Then you have RCFs, which are your residential care facilities. And they basically take care of people who can't live independently, but that's even on a lower level than your IPLs, than your SNFs. These are all term long-term care. All right? You have specialized facilities, meaning they provide specialized treatment, like your rehab facility, site, children's hospitals, burn facilities, dialysis centers. These will all be termed specialized facilities. Then your ambulatory care. This is your care done on an outpatient basis, and you got different types of ambulatory care facilities. You have like your primary care, which would be your physician offices. We talked about your emergency room or your emergency department. That is considered ambulatory care. You also have your ambulatory surgery facilities where patients can get surgeries on an outpatient basis. Certain types of surgeries, they can go in, they'll be out, and they're not staying overnight. You got home care. That's services provided at a patient's home. You have hospice for your terminally ill patients and their caregivers. And you have what we call respite care, where they give relief to the caregivers of terminally ill patients. You have hospitals that actually are in what we call hospital systems that can include a lot of these different types of care. So they'll have acute care, they'll have ambulatory care in terms of physicians in their hospital system. They might have home health departments in their hospital, hospice services on an outpatient and inpatient basis. So you can find these in hospital systems. And then within your hospital systems, you got hospitals that are designated at different levels. You got trauma center hospitals. And the thing with that emergency room situation, that can get very expensive if you have a lot of patients that come in for conditions that are not designated as emergency room type conditions. This can be pretty costly. So there are certain hospitals or certain types that actually place restrictions on these types of facilities. Certain payment insurance plans will make patients have to have pre-authorizations for certain types of care. and that can include ER type services to kind of limit them utilizing these services inappropriately. So some plans have that going on. But when you're looking at ambulatory care, you also have these different levels that they talk about are different in terms of ambulatory care. You have what we call encounters, occasions of service, and visits, and they do manage and keep up with this type of information on how many encounters that they have, how many occasions of service, how many visits. When we're looking at an encounter, that's nothing other than that direct professional personal contact between a physician and a patient. It doesn't include ancillary services like your labs and other things, but it's just that actual contact between the interaction between the healthcare provider or physician and that patient when they're actually treating that patient. Okay, that's what we when we say encounter. Now, when we're talking about the occasion of service, this is looking at those ancillary type services, those identifiable services that are involved in the care. It's not the encounter itself. So like a lab test or x-ray, this is what we call an occasion of service. It may be the result of the encounter. And then you have a visit. That is one single encounter that includes all the services that occurs during that encounter. So in a visit, you may have several occasions of service, but they actually maintain all of this information. A facility maintains data on encounters, occasions of service, and visits. They can take that information that they collect and they can analyze different patterns that they may see and then properly appropriate care. All right, payers, payment providers, and third-party payers. Hospitals will use payer class categories in order to maintain statistics on the different types of payers or insurance companies that they're doing business with. And they'll have several types. So they may have, Medicare, Medicaid, private insurance like Blue Cross, and they keep track of this, what patients have, these types of insurances. And you got different types. You got your insurance carriers that will include your private insurance and your governmental type insurances. Private being like your Blue Cross Blue Shield, your government insurance like your Medicare, your Medicaid, your insurance that comes through for your military participants. These will all be your insurance carriers. You have your MCOs. These are your managed care organizations that actually includes like your health maintenance organizations and your preferred provider organizations, your HMOs and your PPOs. Your managed care organizations, they provide and manage all aspects of that patient care, and they have different forms. Some of different forms of plans that they use to do that. Some of them are more restrictive than others. So that HMO is a type of managed care organization where your care is going to be provided through select physicians or providers that we call your PCPs or your primary care physicians. These primary care physicians act as gatekeepers because they're going to manage all care that you will receive outside of the parameters of your primary care. So, and they will provide referrals to the patient to go see specialists or like a dermatologist or a diabetes specialist and those types of things. So they kind of manage and determine when you need to be pushed out to these specialists or any other needs outside of primary care. So those are your PCPs, and that's how your HMOs work. Now your PPOs provides a little more flexibility in you being able to go outside the network to receive services from hospitals or providers that are not necessarily contracted with the managed care organization. But generally, when you do that, there is an added cost out of your pocket for going outside the network. But the PPO, it can be a form of a managed care organization. It's all about reducing those costs and looking at the utilization of services. Now, then you have self-pay. This would be an individual who does not have insurance, and therefore they're going to pay the full cost of the services out of their pocket. All right. So the main point to all of that was with your hospital statistics, they keep track of financial data and financial information on these payers, and they have payers and payer classes in which they track this information. All right, now we're going to talk a little bit about classifications. They classify your beds and bassinets. They classify service units where the care takes place, and they have other service classifications that they use. And we take that information and have statistical computations on that information. And so we need to have some understanding of how they classify this information. And we're going to start with our beds and bassinets. When we're looking at inpatients, when you go in as an inpatient, you are assigned a bed or bassinet, depending on what type of patient you are, and they compute statistics on this. You have several types. You can have what we call an adult bed, and your adult bed is simply beds in which we place the adults in for inpatient care. Those above the age of children is how your textbook sort of puts it. Then you have children beds, and what we understand here is that there is no universally accepted guideline for classifying children. So it's going to be sort of based on the facility in which you work. But commonly, you will see 13 years old or younger being classified as children. You may even find facilities that have an adolescent classification category. Again, it'll be up to the facility if they have that in terms of who would be classified as what would be classified as an adolescent bed. Now, what you also need to know that a children bed is not the same thing as pediatric. So children bed and a pediatric patient is not synonymous. When we talk about children bed, again, we're talking about those occupying a bed age, if they're going with 13 or younger or whatever that facility stipulates. However, if we're talking about a pediatric patient, we're referring to the type of treatment that patient is receiving. Maybe they are being treated on the pediatric unit of the hospital, therefore that's a peds patient. The same rationale as your book brought out for a child being treated for leukemia. They would be on the oncology unit, so they would be an oncology patient. And so we're not talking about a child bed, they would be an oncology patient. All right, so those are not the same thing. So we got adult beds, children beds, you may even see adolescent beds, more likely not. Most of the time you see adult beds and children beds. Then there are other types of beds that we can consider. You got temporary beds, and what does that temporary mean? It's not on a long-term basis, right? These are not included in bed stats. These are beds that are used for temporary purposes, or things that are going to occur that's not going to be long-term. And your book gives you examples. Disaster beds, maybe we have a hurricane going on or something and they have to set up beds in the hallway or something that are not on a normal basis. That would be what we call temp beds. Your delivery room and recovery rooms are temp beds. Those beds, you are usually there for a little while. Like if you think about obstetric patients, and you deliver the baby in the delivery room bed, but what happens after that? They're going to assign you to an actual room. And so those delivery room beds are temporary because you're not going to stay there your entire stay. Then you have observation beds. These are temporary beds. Observation beds are more or less an outpatient bed. They kind of put you there and monitor you for 24 hours to determine if they need to admit you as an inpatient, trying to see the nature of your condition. These are temporary beds. You're not going to be there the entire time if you are or you happen to be admitted. Swing beds. Swing beds are, the connotation of swing, it means it's going back and forth. It changes. So with a swing bed, it changes purpose based on the needs of that facility. And this will be common in what we call rural hospitals. Rural hospitals have less than 50 beds. And therefore what ends up happening is they need some flexibility there depending on what's going on, so they change the use of the beds. They can serve as either acute or long-term care beds based on their needs, so we call those swing beds. And then finally you have bassinets, which you will find in like your newborn nurseries, all right? So they do collect bassinet data as well as your bed data. So first of all, we need to realize what a newborn is defined as, because the newborns are who occupy your bassinet. Now your newborns are patients that are born in the hospital at the beginning of his or her current inpatient hospitalization. So when the mother comes in, gives birth to the baby, and it's a live infant showing signs of life, we're going to categorize that patient as a newborn, and they're going to occupy a bassinet. Now, if that baby is born as a stillborn infant or as a dead fetus, then this is not going to be classified as a newborn and is not going to be included in the bassinet data. And it's not going to be classified as a hospital admission. So in order for it to be counted as a bassinet usage, and it has to be first counted as a newborn, and the newborn has to be born during that admission, and they have to be alive, showing signs of life. Now you have other classifications. You got service unit and service classification. They use service unit classifications to indicate where and by whom services are provided. All right, and so you have what we call medical care units, medical staff units, medical service units. Your medical care unit designations are based on your type of care or by the unit location. All right, so usually when that patient comes in, they are going to be assigned to a unit to whatever care that they need to receive. So if they're having some neurological issues, then they're going to be assigned to the neurology unit, then that will be a neurology patient. All right, so that's how that works. Or they can be designated by location in the facility. Your book gives you an example. It could be 3 South for 3rd floor, South wing. So they may classify that patient as 3 South. That's looking at location versus the type of care. So it can go either way. Medical staff units are based on or factored on, they determine these classifications based on how big that facility, how many physicians, what type of treatment they are offering to their patients, the type of organization, type of medical staff organization that they have. So these classifications can differ from facility to facility based on these factors. Now you can have a facility that may be smaller, maybe not as big, and so they're not going to have a lot of formalized classifications or a lot of multiple classifications that broke down into subsets, and you know, it gets pretty formal because they're very large and big. And you can have a smaller type hospital that lacks formal organization, and so they're not going to have, maybe they don't have a 2 or 3 classifications, where a large hospital may have multiple classifications, lots of classifications. But there are basic ones that you're probably going to see across the board at most healthcare hospital facilities, and your book talks about those. You got a medical classification, surgical, obstetrics, and newborn. Those are 4 basic common service classifications. Obstetrics, we already kind of know that those patients come in with pregnancy conditions, hospitals still alive to give birth or to deal with some type of condition that is related to their pregnancy, then they will be an obstetric patient or OB patient. Deliver, admission, even if they're not delivered based on what they're coming in for, as long as it's pregnancy related, they will be deemed an obstetric patient or OB patient. Now you got surgical patients. That means they're coming in for operation or some type of surgery. Now this is the exception to that will be your obstetric patients who say maybe they're getting a C-section. That's not going to be included in the surgery. That will be an OB patient because that's related to a pregnancy condition, right? But it tells you that that C-section will still be included in your operating room statistics, even though that might not be a surgical patient. You got newborn. Again, we already talked about the definition of a newborn, and so when that occurs, then they're going to be an NB patient, a newborn patient. Then you got your medical classification that's pretty much a catch-all of everything else if they're not classified as any of the other 3. Then we'll say they're a medical patient, medical classification. Okay? Now, you also have service classification. So we talked about the different units, but you can have service classification. Your medical care unit don't have to correspond to your medical staff unit. And so what is going to happen is when that patient is admitted, they're going to end up having a service classification of some type. Now, depending on the healthcare facility you may be at, some of them require you to assign a service classification at admission. But more than often, at least even if they don't do that, you definitely would provide a service classification upon discharge. Now, what may happen is because things actually change, say you do apply a service classification at admission, that may change by the time that patient is discharged. If that patient has moved or started getting some other type of care, it's really going to be based on where the majority of that care was received. And there are statistics that are generated based on those service classifications, and that allows them to compare. So although some may have you assigned on admission, it may change over the time of that patient's admission. By the time they get to discharge, that service classification may have changed. They're going to gather those statistics based on those classifications so they can make comparisons between those patients that have similar conditions. They can look at or determine utilization. And they also can do some future planning based on these statistics generated from how many patients that are coming through our urology department or our neurology department. Do we need to expand here because we're getting an influx of patients on the cardiology unit and those types of things. So when you are classifying these patients or trying to assign them to these service classifications, your book tells you that there are different factors that will help you in assigning these service classifications. One thing, you can look at the principal diagnosis. What principal diagnosis and the procedures that that patient has had during their hospitalization. What's that condition they came in for? That will kind of lead or guide you to the type of treatment and on what unit that treatment will be received. What type of specialty is that physician that is providing the treatment? That will give you shed some light on the possible service classification of that patient. The type of treatment that they're giving that patient will also do that for you, and what unit that patient was on during their hospitalization. All of this will aid you in assigning that service classification to that patient on discharge. Now, the service classification that you're choosing from is going to depend on those classifications that have been created at that facility in their policies and procedures. Now, in your textbook on page 31 and page 32, they are providing you with some examples of service classifications, and these are the ones we're going to be using throughout our textbook. You got diagnosis classification, service classification, and surgical classifications on page 31 and 32 of your text that you can take a look at. But again, there's no universal classification system, so it's going to depend on your facility. Now, your book also tells you when you are doing certain activities related to these service classifications. In this textbook, you're going to assume that the medical staff units and your service classifications are going to be identical to your medical staff units. Because I had just mentioned to you in real life in facilities, that's not always the case, but for our textbook, this is the assumption we're going to make. Let's talk a little bit about transfers. Patients can be transferred upon discharge. Even while they're being hospitalized, they can be they can have what we call intra-hospital transfers, where they're transferring from one medical unit to another medical unit. Maybe whatever their diagnosis or their levels of care have changed somewhat, and they may need to be moved. You can see that in terms of examples. Maybe that patient is on one particular unit. If he starts experiencing conditions that increase the level of care that is needed, he may have to move to the intensive care unit. That's called an intra-hospital transfer. All right, they maintain data on transfers within a hospital itself, intra-hospital transfers. The records are going to indicate every time that patient transfers during that hospitalization. You have what we call transfer in, TRF-IN, transfer in. When a patient has been admitted into a unit. You have transfer out when that patient is discharged from a unit going to be reassigned to another unit. So you got transfer ins and transfer out. All right? Then you have what we call discharge transfers. And this is when that patient is ready to they're going to be discharged from the actual facility, and they are going to a new facility to aid in continuity of care. So we call this a discharge transfer. And so we do collect information, what we call the disposition of the patient, and then what we call discharge status. Where is that patient going at discharge? If they are leaving without our blessing, we call that AMA, against medical advice. Now, they can also, if they die or expire in the hospital, this is also considered a discharge. All right? So we do collect information on the discharge status of a patient. They can be going alive to home, alive to another facility, or expire. This is all different discharge statuses. Okay? Now, we talked about patient data collection in the previous chapter, but we have a little more. We're going to expand on that idea in this chapter on data collection. And it talks about different ways that we can collect that information and ways we get the information, different sources. Now, information can be collected concurrently or retrospectively. If we are collecting information on a concurrent basis, that means we are collecting that information while that patient is still hospitalized. All right? If we are collecting information on a retrospective basis, that means we're collecting after that patient has been discharged. They're no longer hospitalized, but we're collecting information after discharge. Retro meaning we're looking back, right? Now, you also can collect information manually or electronic collection, right? And we know exactly what that means if you're going to manually enter something in versus it electronically being collected. We also have to, well, if you think about electronic collection, things like they have things that can monitor and record body functions that and it automatically pulls that information from the device and puts it in the system. That's electronic data collection. All right? That's an example. We also talked about we have to be concerned about how much data we're collecting. Is it what we actually need? Your book talks about things we need to consider in terms of how much data we're going to collect. What reports are needed routinely? We need to talk about that. What information is required by outside agencies that we have to comply with? What ad hoc data requests are made? Ad hoc means not planned or impromptu requests. All right? Are there data needs not being met? And so in other words, is there some information that's being needed but we're not collecting that information? This can help guide us in terms of what amounts of data we need to be collecting. Now also consideration, where do we get this data? We can pull this down from different sources. We got primary and secondary sources. What's the primary source? We've talked about this many times. It's the patient's medical record where that treatment is put right into that medical record. That's our primary source of information. Secondary source of information is information that's abstracted from the primary source. All right? And we talked about a multitude of different things that is abstracted from our medical record. What do we have? We have case abstracts. Cancer registries is a very good example. This what we're considering now secondary sources of data. Case abstracts is information you're going to pull from your primary, and you can create a database of that information. It's information in a more concise form, pulling it from that primary source. All right, but you can have different. Cancer is just one example. You can have all types of databases you can create through abstracted information from your primary. In terms of your cancer registries, you'll see that there's a centralized state cancer registry database where all the information is actually pulled from your primary care records to generate your cancer registry at that particular hospital, and then they create big state databases via all that flow of information from the patient record through the hospital, through the state registries, and on to national registries. You got lists. A lot of times your admission department is responsible for a lot of lists that you have. You can have your discharge list, your transfer list. We can pull information from there, but where do those lists generate that information from? Your primary. That's why this is a secondary source of information. You got your indexes, and we talked about indexes in HIM 1000. You got several types. You got your master patient index being one of your main index that stays there indefinitely, right? It helps us keep track of the patients at our facility and their medical record numbers and those types of things. You got disease indexes, identification number indexes, procedure indexes, physician indexes. Because what does that index help you to do? It's just like an index in your book. It's a guide to locating information. But we're abstracting all that information from our primary, our medical record, right? You got registers and registries. Again, these This is secondary information. Your register is a chronological list of data in a healthcare facility, and your register, they serve as references. All right, so you got admission discharge registers, you got birth and death registers, and then you got registries. All right, we talked about the cancer registry. These are large databases with collection of abstracted information on a particular condition that we may have interest in. And finally, the final secondary source we're going to talk about is your incident reports. We use incident reports to assess risk in the facility, and also to minimize and eliminate potential risk in the facility. So we take that information to identify trends and to determine what type of corrective actions we need to put into place. But again, the incident report, where is this information coming from? It's secondary information. It's not coming directly from patient treatment, therefore it's considered a secondary source. Now this is going to conclude our presentation on Chapter 2, Healthcare Overview and Patient Data Collection.